Assalamu alaikum. Our lecture is congenital heart disease. Our objective is to know the classification of congenital heart disease and etiology. We have two types of congenital heart disease. It is either acyanotic heart disease, there is no cyanosis. An example of it is VSD, atrial septal defect, aortic stenosis, pulmonary stenosis, and atrioventricular septal defect, beta ductus arteriosus. A second group of heart disease is cyanotic heart disease. Example of it is tetralogy of Fallot, transposition of great artery, hypoplastic left heart syndrome. Other objective is to know the epidemiology, features, and management of common type of cyanotic heart disease. We go to in detail in our lecture, VSD, ASD, and pulmonary stenosis. Number 3, to know the key presenting feature of atrial ventricular septal defect, and BDA clinically, and how we can diagnose it depend on ECG, chest X-ray, and echo. 4, to outline the basic medical and surgical management of VSD, ASD, and BDA. The last objective is atrioventricular septal defect, or what is known endocardial Cushing defect. Describe the anatomy and the marker characteristic in this condition, and to be aware of association of this condition with Down syndrome, and outline the presenting feature of this condition clinically and how we can diagnose by ECG and chest X-ray. Congenital heart disease, these are abnormality in the cardiocirculatory structure or function that are present at birth, even if it is discovered later. Incidence, it is 0.8% in normal population, and the incidence is increased with each pregnancy, and in second pregnancy become 2 to 6% if the family has the first child affected with congenital heart disease, and the incidence increased to become 20 to 30% if the family has two other siblings have congenital heart disease. Etiology of congenital heart disease, it is multifactorial, which is there is genetic and environmental factor. Example of genetic causes of congenital heart disease, it is either associated with a chromosomal anomaly like Down syndrome, Turner, Edward, it is associated with congenital heart disease. Number 2, supracrystal VSD is more common in Asian population and increased incidence in the first degree relative affected. Chromosomal deletion like chromosome 21 at the position of 11, a long arm of this chromosome, which is called DiGeorge syndrome. Number 5, cardiomyopathy has genetic causes, and number 6, heritable arrhythmia. Environmental causes of congenital heart disease like maternal diabetes mellitus, it is increased incidence of congenital heart disease. Phenylketonuria, congenital rubella, SLE in the mother, drugs, lithium, ethanol, warfarin, thalidomide, and antimetabolite, anticonvulsant. These drugs will lead to an increased incidence of congenital heart disease. Acyanotic congenital heart disease, we classified into two groups. Groups that cause the volume overload because of the shunt from left to the right, which include VSD 25, atrial septal defect 10%, beta ductus arteriosus 10%. And the other groups which cause pressure load due to pulmonary stenosis 10%, correlation of aorta 8%, and aortic stenosis 6%. This diagram shows the ventricular septal defect on the shunt that cause left to the right shunt, and mixing of oxygenated blood with the right ventricle contain deoxygenated blood. Pathophysiology of ventricular septal defect. There is this is cause shunt, the communication of blood, and the blood will be go from the left ventricle to the right ventricle. The shunt depend on the size and on number 2 on the ratio of equation between QB and QS ratio. Number 1, the size, when it is either we classify VSD into restrictive or into large and non-restrictive. Number 2, it depends shunt on the equation of QB to the QS ratio, which is mean pulmonary to systemic blood flow. Pulmonary to systemic blood flow. When it is a small VSD, this ratio will be less than 1.75 to 1, and when it is large shunt, the large more than 2 to 1, يعني go the pulmonary blood flow 2 and to the systemic circulation 1. When a small communication is present, usually less than 0.5 cubic centimeter, the VSD is called restrictive, and right ventricular pressure is usually normal. And when it is large, not restrictive VSD, usually more than 1 cubic centimeter, usually the right and the left ventricular pressure is equalized. The functional disturbance caused by ventricular septal defect magnitude of the left to the right shunt depend on the size of the VSD and the degree of pulmonary vascular resistance, not on the site of VSD. Now, when it is large VSD, there is no resistance to the flow. Say there is large shunt from left to the right, and there will be progressive increase in right ventricle pressure, and later on increase in pulmonary artery pressure. With the time, with increase this shunt, there is an increase in right ventricle wall thickness and result in increased pulmonary vascular resistance and cause reverse shunt. This is a more severe and progressive case, which cause reverse shunt from right to left. When this condition is reached, it is called Eisenmenger syndrome, which is irreversible and the patient cannot do operation, and it is irreversible. First, when the start of the condition, there is left to the right shunt, but with the time, with an increase in the pulmonary vascular resistance and an increase in right ventricular pressure, the shunt will be reversed, become right to the left, and the patient will develop cyanosis. This condition is called Eisenmenger syndrome. In a small VSD, there is high resistance to the flow through the VSD, so there is a small left to right shunt and the pressure is normal in right ventricle and pulmonary artery. Clinical feature of ventricular septal defect, it depends on the size of defect. When it is a small VSD, which is most common, it is usually asymptomatic and it is discovered during routine examination. By auscultation, we hear hollow systolic murmur. Immediately in neonatal period, there is a left to the right shunt minimum because of that lead that to the murmur may be not heard. In premature, the murmur it is heard earlier. When it is large VSD, the clinical feature is more obvious. There is dyspnea, feeding difficulty, poor growth, and the patient liable more for chest infection. Cyanosis is usually absent, but duskiness, especially during infection. On examination of the baby, there is a palpable parasternal lift, lateral displace impulse, and systolic thrull. Systolic thrull and hollow systolic murmur less harsh. Pulmonary component of second heart sound is increased, and there is mid-diastolic rumbling murmur increase at the apex when the ratio of QB to the QS ratio 2 to 1. Now we speak about the diagnosis of VSD. We depend on the ECG, chest X-ray, and echo. First, ECG, when it is a small VSD, the normal, there is no finding in ECG. But when large VSD, there is biventricular hypertrophy, we find enlargement of right ventricle and left ventricle. Chest X-ray in a small VSD, it is normal, but when it is large VSD, cardiomegaly, dilated pulmonary valve, pulmonary vessel due to increased blood flow through pulmonary artery, and increased circulation to the lung, become a plethoric lung, because of a large amount of the blood go to the lung. And number 3 of investigation, it is echo, which is essential for diagnosis. By Doppler echo must be done in all patients for the following: to know the size of the VSD, anatomical location, size and direction of intracardiac shunt, and the degree of pulmonary hypertension and the presence of other associated anomalies. Sometimes VSD it is associated with other congenital heart disease like tetralogy of Fallot. Number 4 of investigation, it is catheterization and angiography. A small number of the patients with VSD require catheterization, not all patients. provide a clear anatomical picture of the location and the number of VSD in patient when the surgery is required, and estimation of the magnitude of the shunt, the degree of the shunt from left to right, and pulmonary vascular resistance to know if the patient is still operable or not, to diagnose the pulmonary, if it is reverse shunt when we speak earlier, Eisenmenger syndrome, which is incompatible with operation. This is very important. And the last thing, to close some muscular VSD with catheter device derivative. Now we speak about prognosis and natural history of ventricular septal defect. It is depend on the size. When it is a small VSD, closure will be occur in about 30 to 50%. Close spontaneously during the first 2 years of the life. Most common in muscular, about 80%, and less common in membranous, which about 35%. When it is a small VSD, usually it is asymptomatic, and with the time, if it is inoperable, long-term sequelae which occur later in life without cause arrhythmia, subaortic stenosis, exercise intolerance when it is discovered later. When it is large VSD, less likely to close spontaneously. 8% may close completely, but it is lead to repeated chest infection because it is pulmonary congestion, and the patient presented with heart failure and failure to thrive. Also, when it is large VSD, most patients need surgical repair in the first year of the life. Without surgical repair, most patients will develop pulmonary hypertension. On some patients may be reached to Eisenmenger syndrome, about 10% of the patient. And some percent of the patient, about 5%, will develop infundibulum pulmonary stenosis. The pulmonary valve gets smaller. This is natural occur because to protect the lung from over circulation. Those with supracrystal VSD, it is type of VSD at the risk of aortic regurg, maybe develop aortic regurg. Small percent acquired infundibulum pulmonary stenosis, about 5%, which protect the pulmonary circulation from over circulation. And there is risk of infective endocarditis irrespective of the defect site. Now we speak about the treatment of ventricular septal defect. When it is a small VSD, reassure the parents no need for operation, only follow-up, encourage patient to have normal life, surgical repair not indicated, and only protect against infective endocarditis with antibiotic, and the patient need monitoring and follow-up by clinical examination, ECG for evidence of pulmonary hypertension, and by echocardiography. But in the case of large VSD, there are medical treatment and surgical treatment. Medical treatment to control the heart failure and prevent development of pulmonary hypertension, and also treatment of respiratory infection, and nutritional support, and prophylaxis against subacute bacterial endocarditis. Now we speak about surgical repair. Surgical repair, either pulmonary artery bounding, we decrease the diameter of pulmonary artery to decrease the blood go to the lung, or maybe do total surgical repair when the patient condition it is تسمح ظروفه أن يسوي له complete surgical repair. Indication of surgery, we have 4 indications for surgery of large VSD. Number 1, any age of the patient with large defect in whom clinical feature and failure to thrive cannot control medically. The patient take treatment but still symptomatic. Number 2, infant between the age of 6 and 12 months with large defect associated with pulmonary hypertension if symptom controlled by medical treatment. Number 3, more than 2 years of age when the ratio of pulmonary to systemic circulation more than 2 to 1. And number 4, patient with supracrystal VSD. This type of VSD must do surgery because the risk of aortic regurg. By surgery catheterization, most muscular VSD and some membranes can close by device placed during catheterization. This the complete of VSD. Now we talk about the second type of cyanotic congenital heart disease, which is atrial septal defect. It is an opening in the intra-atrial septum other than patent foramen ovale. It is more common in female with a 3 to 1. It has three types of atrial septal defect. It is premium atrial septal defect when it is located in the lower part of the septum that separated the right atrium from the left atrium. On secondarium atrial septal defect in the middle, about 80%, which is the most common, and the last one, it is sinus venosus in the upper part, about 10%. In atrioventricular septal defect, there will be chronic left to right shunt, which causes volume overload on the right side of the heart, result in dilatation and an increase in pulmonary blood flow. This is the diagram show the atrial septal defect. Clinical feature most often it is asymptomatic. In young children may cause failure to thrive. In older children lead to exercise intolerance. On examination there is mild left pericardial bulge and loud first heart sound. On the most characteristic of atrial septal defect, it is fixed wide and fixed splitting of second heart sound. There is a systolic ejection murmur, and sometimes we hear rumbling diastolic murmur when the ratio of pulmonary to systemic circulation more than 2 to 1. Diagnosis by chest X-ray, there is right ventricular enlargement, round apex beat, and an increased pulmonary marking due to an increased blood flow to the lung. ECG, there is right axis deviation and incomplete right ventral branch block and peak P wave due to right atrial. Echo, which is most important for diagnosis, and catheterization, not essential for diagnosis, indicated only for treatment, and exclude other associated anomaly with atrial septal defect. Natural history, it is benign lesion, rarely cause heart failure or pulmonary hypertension, and rarely cause infective endocarditis, and it is rarely cause spontaneous. The treatment, if the patient is symptomatic or the ratio of QB to QS ratio 2 to 1, then surgery is indicated by transthoracic device closure, and it is done after 1 year of the age and before intervention. This is the diagram show the device located during catheterization to close the atrial septal. Prognosis of the atrial septal defect may close spontaneously during infant, may be tolerated during childhood. The symptom not appear until third decade of the life, which may be presented with arrhythmia, pulmonary hypertension, heart failure of mitral or tricuspid insufficiency, infective endocarditis rare and need no surgical, no prophylaxis with any. We talk about pathophysiology of endocardial Cushing defect in osteomobrymium. When it is partial, there is left to the right shunt, there is mitral insufficiency, but pulmonary artery pressure it is normal. And the clinical feature we have similar to the atrial septal defect. In complete atrioventricular septal defect, there is a left to the right shunt at atrial and ventricular level. At both level, atrial and ventricle, which is valvular insufficiency, cause increased volume load on one or both ventricle at increased pulmonary vascular resistance, which is with the time cause reverse shunt right to the left shunt, and the patient will develop cyanosis. Diagnosis of endocardial Cushing defect by chest X-ray. We found marked cardiac enlargement, pulmonary vascularity, and increase and pulmonary artery enlargement. Number 2, by ECG, we found right axis deviation of QRS, right ventral branch lock, or right ventricle hypertrophy. Number 3, by echo, we found right ventricle enlargement, septal deficiency. And number 4, by catheterization. And number 5, by selective left left ventricle ventriculography. The treatment in osteomobrymium with surgical correction. When there is complete atrioventricular defect, there is risk of pulmonary hypertension during the first 6 to 12 months of age. Surgery is in early infancy is indicated. Sometimes do pulmonary bounding of too small baby or associated with deformity that makes surgery it is risky and costly. Natural history of atrioventricular septal defect. It depends on the size of various atrial and ventricular defects and the amount of mitral regurgitation. And the osteomobrymium with no mitral regurgitation has the same benign natural history of simple secondarium ASD. but when there is complete atrioventricular canal defect, heart failure and or pulmonary vascular disease may be occur. The other subject we last discussion in this lecture, it is patent ductus arteriosus. It is a channel that connected the pulmonary artery with the descending aorta. Isthmus part of the descending aorta. It results from persistent of patency of the fetal ductus arteriosus after birth. It is the most common lesion in infant of mother with congenital rubella. BDA more common in female. Normally, functional closure of ductus arteriosus occurs at 10 to 15 hours after birth. If it is persistent open after pulmonary vascular resistant fall lead to aortic blood shunt to pulmonary artery. The blood shunt from the aorta to the pulmonary artery. It is more common in female. The site mallet at the aortic side distal to the origin of left subclavian artery. The pulmonary side at the bifurcation. Why it is not closed? In premature normal structure due to hypoxia and immaturity. In term baby, BDA has structural mean it has structural abnormality. In term baby, it persists beyond the first few weeks, mean not close spontaneously. Most of the cases in premature close spontaneously. 10% associated with other congenital heart disease. This picture shows the pathophysiology of BDA, which is lead to the left to the right shunt, which is depend on the size of the defect and the ratio of pulmonary to systemic vascular resistance. Clinical feature: when it is a small BDA, it is either asymptomatic, heart size may be normal. When it is large, heart failure, growth retardation, bounding peripheral pulse, wide pulse pressure, and large heart, apical impulse prominent. There is a thrill, there is machinery murmur, which is the most characteristic, and mid-diastolic murmur at the apex. Diagnosis by ECG. In small BDA, it is normal, but large BDA, there is normal axis deviation, left ventricular hypertrophy, or biventricular hypertrophy. By chest X-ray, cardiomegaly, plethoric lung, and prominent pulmonary conus. Treatment: we must closure of BDA irrespective of the age. Indomethacin is often effective in closing the BDA in premature neonate by decrease prostaglandin E1 level. Closure by number 1 by thoracoscope, decrease post-operative discomfort and scarring, or number 2 by transthoracic. Either it is a small by coil, when it is large by sac in which several coil release, or umbrella-like device cause closure of BDA. Thank you. This is the end of the first lecture.